We have John Broyles, CEO of the Coalition to Transform Advanced Care, Gary Backer, Chief of Strategy, Policy, and Legal Affairs, Capital Caring Health, and Tori Fields, Chief Executive Officer of Votive Health. C-TAC submitted the Advanced Care Model, ACM Service Delivery, and Advanced Alternative Payment Model in 2017. Please go ahead and remember to unmute yourself as you present.
Thank you. I'm going to do some framing at the outset and then turn it to my colleague, Gary Backer, who was part of the team from 2017 that submitted and spoke before the PTAC. C-TAC is a large alliance of nearly 200 organizations. You may not know C-TAC, but you likely know our members, AERP, American Heart Association, American Hospital, large systems, and health plans. And our focus is on transforming the experience of the patient and family from the point of diagnosis through to the end of life. So we're here speaking on behalf of the patient and family. Next slide, please. So our story today begins, from 2017, where we were last before the PTAC, and two things happened after that. One is you asked a lot of great questions, tough questions that helped us refine our proposal. We worked with the American Academy of Hospice and Palliative Care directly with CMMI to advance the key elements of the proposal that we reviewed with you into new payment models and heavily informed the CMMI Primary Care's initiative. So number one, thank you for your feedback and know that you are having impact. The second thing is that we had a realization that as sophisticated as the model of care that we submitted was, it wasn't enough. And so next slide, please. Because to really reach those who are completely outside the system, we have to work not just through Medicare eligible providers, but really intentionally in partnership with the community. And that brings us to the story of Shirley Roberson. Shirley was a colleague of mine, a friend, in fact, and recently a board member of C-TAC. She lived with advanced cancer for over a decade. And during that time, she really taught us that trust is key. The relationship with the patient is key to this entire discussion around total cost of care. And really, it was during many ups and downs, many challenges with social isolation, challenges with transportation, food, pain for her, that her cancer was causing, that her faith community really stepped up. And Shirley would often say to me, when you feel like giving up, it's the community that's going to keep you going. And that's always stuck with me. And now she thought of community as including her oncologist, who would not just help her with her pain, but also remember to give her a hug and check in and see how her art was doing. But it also included the Area Agency on Aging. It included her church, Hartford Memorial Baptist. And I think as we think about where to go next, where the greatest opportunity for innovation lies, we believe that it's in reaching those who are completely outside the system, those who have been underserved for too long, and those who need investment in trust and trusted relationships. So as we think about how to get there, we have to think seriously about investing in the organizations that folks like Shirley believed in, not just as a charity, not just as community benefit, but as true partners as we move this $4 trillion health system that we have towards more person-centered care. And I'm going to turn it to my colleague, Gary Backer, to talk about some of the practical elements behind our recommendations there.
Great. Thank you, John. So thank you again for having us. It's a pleasure to get to come before the panel again. As John mentioned, we got to do this a few years ago. There's a couple of important themes to pull through that came from the earlier discussion with the PTAC, and I had the pleasure following our PTAC presentation actually become the Chief Strategy Officer for CMMI and help oversee the architecting and development of a wide range of the models that are being used today. And I think there's two important themes that emerge kind of from the conversation we had with the PTAC earlier and part of our work today. So one is we're strong believers in the power of total cost of care per a lot of the conversations that have been conducted today, but it's also important to ask about total cost of care for who, and to think about the different subpopulations that are being served under any particular model to make sure that things, in a sense, don't get over average. So paying attention to important subpopulations, not necessarily carving them out, but being aware in model design that if you're taking care of a substantial portion of people that are of a particular subpopulation, it may be important to kind of make sure that the model parameters are flexible enough so that it can accommodate those populations and make it feasible to successfully serve those people. Second point has to do with nested models. And I say this all the time. One of the things that I remember from the PTAC discussions before was the discussion around, does it make sense to have broader nested models or standalone models? And the idea is we talked about, at the time we were proposing a model to focus on the seriously ill, which really did inform a lot of CMMI's work. And one of the discussion points was, well, why would you want a standalone model to focus on the seriously ill if we already have many longitudinal total cost of care models where their incentives should already be in place to actually focus on the seriously ill people with advanced illness? And we thought, and we still think, that that's actually a very, very valid point, but there's also some issues where if you build it they won't necessarily come. And so one of the questions is, how do you really have the right balance between broader population-based models where you are creating the right incentives or even minimum requirements to be able to offer certain kinds of services, a minimum of services, for instance, that should be used to make sure that everyone with serious illness receives the right care? How do you do that in balancing between a nested design where you have that as part of a broader longitudinal model versus a standalone model? And our view is, in general, you should try to avoid, and I'll use the term disintermediating, those that would be taking total cost of care and total quality responsibility for a population, but at the same time, you want to make sure that there are, for those patients that are not going to be aligned to some kind of a longitudinal model, that there is, for instance, a standalone opportunity so they can receive services that are important to their care. And then another point that we've taken away is really systematically identifying and addressing and assessing populations' needs. And John made this point very well, the importance of actually focusing on those around people that are giving them the support. And so really honing in on caregivers who do amazing work, but recognizing that they suffer a great burden. And how can we in the different models actually, for instance, do a better job of supporting caregivers? And that leads to the final point, which is how do we do a better job of bridging the divide between healthcare and the community, the divide that John spoke about. And if you think about our models, most of them really have a sort of a medical provider construct to them. So very typical in a model, there'll be a participant provider and a preferred provider, but we don't really have formal room for the community in our models. And so beginning to think about how do we do that and how do we actually create new infrastructure on the ground. Sometimes we refer to it as a hub or a marketplace where we can, for instance, bring together healthcare organizations and community-based organizations and provide support for those community-based organizations, whether it's with contracting or data management and reporting. And then finally, the one hard issue we're going to have to address is ultimately how do we pay for these services? Because if we're talking about Medicare beneficiaries, Medicare has a big gap in terms of its coverage. And that's because it really doesn't pay for non-medical services. It doesn't really have a clear payment stream for services that meet people's social determinants of health. It doesn't have a payment stream that meets what in the Medicaid world we would call long-term services and supports, and it doesn't really have payments for long-term care. And so we really have to begin to figure out, given those deficits and those gaps, how do we, for instance, find ways to pay for services that would close the gaps that people have. And a lot of that, I think, begins with bridging the divide between the healthcare world and the community. So with that, I'm going to turn it back to the panel. Thank you very much for having us.
And I'll just say to end our presentation that we've included 2 emerging community-led models that are partnering with health systems in the appendix of our slides, the Alameda County Care Alliance and the Coalition for Serious Illness Care in Arizona. So thank you.
Thank you so much, John and Gary. You can tell from these presentations we've covered a lot of really rich and interesting ground. I'm going to open it up now for the committee to ask questions. You can raise your hand to be added to the queue, but please go forward, committee members.
I'll start. John and Gary, as I recall your 2017 proposal, one of your objectives was to break down the silos between curative and palliative care. Have you been able to accomplish that in the work that you've been doing in the places where you're operational?
It's a great question, Bruce. I'd say it's a ongoing journey, but we have made lots of progress, and we'd like to share what we've learned with you. I turn to Gary to comment, and then we also have our colleague Tori Fields, who has been working on this issue really closely at the operational level. And Tori, maybe you can speak to this after Gary.
So one thing I'll mention is there's actually a couple of the models that CMMI has put in place that directly address the idea of concurrent care. So 2 examples of that would be in both direct contracting, what will become the REACH ACO model, and then also in the Kidney Care Choices model, there's actually a concurrent care hospice waiver. And a lot of that inspiration really came from the idea that we should be looking at ways to make it easier for people, if appropriate, to be able to access hospice. And a lot of that, there's also has been the Medicare Care Choices model, or MCCM, which was designed to also sort of test what's the effectiveness of being able to provide people some degree of conventional care in addition to supportive care. So there's actually been several models that have moved in the direction of trying to provide more flexibility for concurrent care. And I think it'll be really important to see what those lessons are. So in the CKCC model and direct contracting model, the KCE or the DCE can allow the beneficiary to continue having Medicare pay for conventional services while the beneficiary actually elects hospice. And that's one of the waivers that's built into each of those models. But John, I'll turn it over to you and Tori to provide some additional perspective.
Tori?
Sure. Thanks for having me today. My background is largely in the private sector and also in the Medicaid managed care space. And from that perspective, there's been a lot of movement since 2017, really looking to build out more holistic models and concurrent models for people with serious illness. So the Blue Cross Blue Shield plans have spent a lot of time really working on this and embedding palliative care services or advanced care planning into their accountable care organization models to require that these populations are then assessed for different services and are actually being delivered those services like palliative care and hospice. And those models are largely on a sub-delegated arrangement where there is an ACO who is actually paying a per enrolled member per month for those services, and they're included in total cost of care. There was a paper that just was recently released about the California model, and the 5 health plans who actually delivered palliative care services across this model all saved money, but also improved population outcomes. They also proved that you could have a multi-payer collaborative across a state and do the same thing. So I think that's also worth noting. On the Medicaid side, there are now 2 states who are implementing palliative care benefits as a concurrent care model, both for adults and for kids, California being the first one that did that on a state mandate through legislation. Hawaii is working now on submitting a state plan amendment that includes palliative care as a benefit. If that gets approved, then there are multiple state Medicaid programs who are looking to do the same thing. And as part of that, what we have to do, and what my team has done for some of those state Medicaid agencies, is to actually look at their total population, stratify them based on their risk and their need, and actually look at that seriously ill population differently to determine what the gaps are in their care. So there's been a lot of momentum and movement on the private side. And as Gary was saying, in the model side, the value-based insurance design for hospice is also an additional place where the carve-in is being tested, and health plans are testing palliative care services with that.
Thank you so much, Tori. I'm going to go next to Larry Kaczynski with his question.
Thank you. I have a question for Valinda. The CCM codes have not had traction for their entire existence, but there was a change in last year's final rule that opened up opportunities for PCM codes.
Mm-hmm.
And we're seeing independent companies develop products now around the promotion of PCM codes. So we should expect to see an increase in their use. The problem I have with this, these are not first dollar claims. The patients are going to be hit with deductibles and copays on them. And I don't know how you place, and I'm interested in your input, I don't know how you insert a PCM or CCM code into the chronic care of a patient when they're going to get hit with monthly copays and hits on their deductible. I just don't see it as a solution.
Right. There have been several medical associations, and certainly APG was one of them, in which we pushed for CMS to not have that be one of the copays, like annual wellness visit. Do you mean it's not a copay? And yet it's classified, Larry, under that. If you look under clinical code services, in which you have ACP, advanced care planning, TCM, CCM, annual wellness visit, you are exactly correct. That should have no copay. I think that is an opportunity for advocacy. I do know that there are some physicians that have said, I feel guilty, doing a CCM code and charging the patient 20%. We have found there is success and decrease, do you know what I mean, in hospitalizations and readmissions using the code. So you're exactly correct. I think it is an error of CMS not to have it on one of the list of no copays.
Thank you so much, Valinda.
If I may add, Valinda, can I just add on the advanced care planning component of that, the copays have been a huge deterrent for people with serious illness. And what we're finding is that 50% of the population who have an advanced care planning billing code dropped is by a specialist outside of the annual wellness visit. So the initial intention of trying to couple these things with primary care or an annual wellness visit just really have not worked out.
Mm-hmm.
So helpful. Chinny, you're next.
My question is for Christina. You spoke about sort of some of the quality as well as economic value in the organization. And what I wanted to ask is what is your strategy for managing specialists as well as post-acute spend, and how do you bring them into your total cost of care methodology?
Yeah, figuring out how to engage specialists in the total cost of care methodology it's a difficult nut to crack. So I will not tell you that we have completely solved that. I would say that when we look at the patient population, the needs of the patient population, the resulting spend pattern by major category of service, that the majority, because in our biggest ACO product line, which is Medicaid, of course, in Medicaid, 80% of what shows up as healthcare need is not sort of pathology, not clinical pathology based, it's not about physical health. That in some respects in the Medicaid population, some of those really difficult to solve issues with specialists are slightly less germane. Probably the best example is the need for access to the specialists under the behavioral health umbrella. This is a place where health centers and organizations like health centers have some advantage because there is a lot in the behavioral health outpatient continuum of care that may reside inside of the FQHC. Access to ongoing therapy, integrative behavioral health clinicians and psychiatrists who do prescribing, that it's all part of primary care team. So that sort of building out the what lives under the house of primary care and making that increasingly expansive has been a good way to address some of these specialty issues by no longer really classifying them as specialty and bringing them into the primary care home. Another idea that we have been working on and we're testing with regards to all of the other specialists is the use of telehealth, both e-consult, so asynchronous e-consult, where it's clinician to clinician via email, essentially, using e-consult as a primary modality to get the need met around specialist care, with, of course, then an exit ramp for individuals who need face-to-face specialist care immediately, or where the e-consult has determined that the patient now needs a visit with the specialist. In certain markets, the other thing that we've been able to do when we find that there's a significant difference in the quality of specialty services is redirect care over to a different system. This is not done through traditional methods of network management or prior authorization. This is really done with speaking with clinicians and having clinicians develop different patterns of referrals based on where they are most comfortable having their patients go. Getting back to the issue of trust, we find that the best way to advise patients, to have patients go to preferred specialists, if you will, is through the clinician, the PCP, the behavioral health provider, the nurse practitioner, et cetera, having more of a clinical comfort with those particular specialists and developing those relationships.
Thank you so much, Christina. Walter, you're next.
Thanks, Lauren. So this is a question for Valinda. Valinda, on your solution slide, you mentioned the idea of curating a central repository, which is actually very timely, as this committee was only this morning discussing the development of a library of care transformation and practice redesign best practices garnered from other disease-specific and episode-based payment models like the oncology care model and the ESRD care model. My question is, how has Upstream populated its central repository with strategies and best practices and disseminated these practices to its participating providers?
Yeah, so I'm going to defer the question since I've only been in Upstream for a month. Okay, so can you ask me that question in about 6 months? Okay.
Sure. Fair enough. Okay, thank you.
I can answer it from a APG perspective that we tried through a lot of webinars and having a central repository in the website to be able, because a lot of our members were independent practices and they had very little access to know what was working. They weren't a part of large organizations that big health systems could purchase, to be able to go in. So we tried to provide that, but certainly having a national database that would be open to everyone would be optimal.
Thank you, Belinda. Jennifer, you're next.
Thanks to all of our presenters for excellent presentations. My question is going to be for Christina, although a number of you have talked about this issue. My question is around, Christina, impressive results with your organization. And being a risk-bearing entity, I was wondering if you could address the two specific concerns that we've heard regarding barriers to participating in total cost of care programs. One is the infrastructure cost. So you describe an impressive data analytics program and plan, which I'm assuming required a lot of capital. And then also this concern around diminishing returns in a program around performance, and how you thought about those, not only in developing your program, but also in maintaining the successes you've seen.
Yes. So on the first one, barriers to entry because of infrastructure costs. There are definitely infrastructure costs. I would say initially for us, based on our scale at startup, we had to spend approximately $5 million in building infrastructure. One of the ideas that we have put forward, and this comment is particularly relevant to entities in the healthcare market who have traditionally had less access to capital because perhaps they are a safety net organization or they are a 501c3 or there have been other constraints on building up the balance sheet, that some of these programs, both local programs that might be run by local Medicaid authorities or commercial carriers, or federal programs, also come with startup capital. When you think about sort of the intricacies of risk-based capital and requirements that the Department of Insurance will have on an HMO, this is based on how much risk the HMO is bearing. When an HMO gets involved in doing business with a provider organization on total cost of care, this is a risk transfer. So I think that one could argue that a source of startup funds for building infrastructure would be the health plan sort of having a redistribution of the risk-based capital that has been held against that account before it was a total cost of care risk account over to the provider organization who wants to enter into risk as in capital investment in that organization's ability to build their infrastructure. On the second point around the law of diminishing returns for high performers, it's a really, really important point. In the Massachusetts Medicaid program, the state has taken some very good steps, not that it couldn't go further, and we advocate for it going further, in having a market blend into the development of benchmark. So that if we are beating the market, right, and we're managing down our own experience, that we have a way of having a blend of our experience with the average cost of what's happening in the market so that it has the ability to lift up our budget. This has been critically important to us at this point in the program, given our success. If we could choose, we would choose a purely market-driven rate. So I think that that is a way for that to happen across the board, locally, nationally, public payers, private payers, to be able to have higher performers choose between experience-rated benchmarks or market-rated benchmarks or a blend.
Thank you so much, Christina. We have one more question from Paul. This has been really rich discussion. I'm sure we could talk for hours. But Paul, can you ask our final question before we go to the break?
Yeah, thank you. And I also want to thank all the presenters for just great presentations. This question is for Belinda. And Belinda, I know, well, first let me say I'm grateful of your work for BPCI because in my former role, leading population health in a tertiary community hospital with multiple specialty groups, I saw firsthand the engagement of the specialties in BPCI, the classic, and then with advanced. So I think we've learned a lot, absolutely. So now as we're thinking towards these population-based total cost of care models, and I know you've been involved in some of these listening sessions, and I'm sure you've been thinking a lot about it. I guess my question is still, as in from your perspective and in your roles, how best to engage specialists going forward as we move to these larger total cost of care models.
Right. So, Paul, I really believe that episodic payment models are the best for specialists, and you need them, or you're just not going to get the level of engagement that you need in terms of moving them to value-based. Total cost of care models is the ultimate way that we need to be there. I have recommended that they really look at lessons learned, particularly in APG. We had a lot of members that were out in California that had had decades of experience in terms of taking capitated delegated risk in the MA population. And as they took it, they started with different relationships with the specialists. The specialists, they would do things like, you had to meet a time, a framework, or a service, or patient satisfaction to get on the list. And they found that that was just not enough, that they actually had to figure out a way to subcap it or look at a bundle, a payment with them. And I have recommended to CMMI that you take the lessons from that. And so whether that ends up being a nesting, does it end up being something that's a blend of both? But certainly I think the specialists need to have, one, an episodic payment to be engaged, and two, the overall platform in terms of total cost of care they are not engaged in an ACO. So somehow I think take the lessons that have decades of experience in subcapping and having the specialists be their partners in that, and not treat them in terms of commodities. And unless you achieve these service goals, we're going to kick you off the list. That didn't work. It doesn't work with anyone. People want true partnerships.
Thank
What a
you.
great note to end on. Thank you so much, Belinda. My great thanks to each of you, each of our experts, for sharing your time and experiences with us.